How to treat inguinal hernia without surgery. Part 1. This video examines the possibility of a non-surgical cure for inguinal hernia existing. It comprises a reading of 4 selected chapters from the landmark 1844 book, The Anatomy and Surgical Treatment of Hernia by Sir Astley Cooper, one of the greatest surgeons of his era. Why would anyone be interested in such a text? Because it is fascinating to observe how hernia was managed at a time when the natural inclination of the surgeon was not to operate. Hernia surgery is not without risk of adverse outcomes. In a 2018 paper by Anderson and Rosenberg in the Journal of Pain Research, link in the description below, it was reported that up to 16% of people experience chronic pain following the repair of a groin hernia. And the true percentage may be far higher. Indeed, medical centers now exist, such as the Cleveland Clinic Center for Chronic Groin Pain, whose principal mission is to attempt to alleviate persistent pain following hernia surgery. So, what methods were used when the decision to operate was not routine, and what were the outcomes? Sir Astley Cooper was one of the preeminent surgeons of the early 19th century, and an authority on hernia. It would be madness to take medical advice from a doctor of centuries past, so don't. Still, in the spirit of inquiry, let us travel back to a time before anesthetics and antisepsis, when operating on the abdomen had a mortality rate of around 50%. Then, there was a strong motivation to treat a hernia as it was, and those treatment methods have been lost to time. The standard approach for the treatment of inguinal hernia today is surgery. However, for an asymptomatic patient with a hernia that can be reduced, the option to wait and observe is now regarded by some surgeons as an acceptable alternative. Links below. Still, the use of a hernia belt, or truss, to support a hernia, so common in the past, is now normally strongly recommended against by surgeons. Yet the scientific literature of the past 70 years is almost devoid of studies on their effectiveness or otherwise. In 1995, Cheek et al., link in the description below, observed that despite the high use of trusses, little has been published on their effectiveness, complication rates, and value. Furthermore, such recent research as there has been into the value of trusses has been occasionally not without bias. In the British Medical Journal, back in 1938, link in the description, Mr. Ralph Coit, Fellow of the Royal College of Surgeons, writes of trusses as follows. The pad must be large enough to cover the opening through which the hernia protrudes. The spring must be covered by a material which is durable and comfortable, such as a soft kind of leather, the patient getting used to the pressure and no injury being done to the skin. It is usually fairly easy to control this type of hernia by means of a truss, except when the protrusion is of considerable size. Half a century later, however, either attitudes had changed or the human body had. In 1992, Law and Trapnell, in the very same journal, link below, strike an entirely different tone. Their paper incidentally cites only 3 references, 2 of which are from the 1970s. The authors conclude, despite finding that a truss controlled a hernia in 31% of patients, we suggest that a surgical opinion should be obtained before a truss is prescribed. In other words, one should ask a surgeon whether surgery is a good idea. This should reduce the need for an antiquated surgical appliance, which is uncomfortable and often fails to fulfill its purpose. This policy would also save money. Firstly, often fails is not the same as always. Secondly, the claim to save money was without evidence and can be dismissed. And thirdly, the statement that asking a surgeon would reduce the need for this quote-unquote antiquated surgical appliance means the message is clear. It is the surgeon's role to dissuade the patient from wearing one. Let us now look at the modern approach. If we go back centuries, no surgeon would willingly operate on a wildly shrieking and kicking patient. No wonder what is now called watchful waiting was the standard care. Over the past 150 years, however, non-invasive approaches to managing hernia have been supplanted by the knife to such a degree that one can forget that there ever were alternatives. Of course, there absolutely is a crucial role for surgery in the management of many or most inguinal hernias. But surveys show often a lack of consensus within the medical community as to how to treat them. In 2020, Jacquet et al., link in the description below, published the results of a survey of 204 surgeons inquiring how they would treat 13 hypothetical hernia patients. The authors defined consensus as occurring when 3/4 of the surgeons agreed to a particular course of action. Yet this only happened in 2 of the 13 cases. Here is an example. A 50-year-old patient is referred to you for bilateral inguinal hernia. He had consulted his treating physician for an embarrassing right inguinal swelling. An ultrasound was performed, confirms the hernia on the right side, and also found a contralateral hernia. At the clinical examination, you find the hernia on the right side, but you do not perceive hernia on the left. Question: what do you propose regarding the asymptomatic hernia? 101 of the surgeons said they would operate, and 103 of them said they would not. Which does show that these decisions are not always clear-cut, and one should not confuse the certainty of the surgeon with the certainty of the facts. Naturally, surgery has risks. If a person has an asymptomatic reducible hernia, it often may not have to be treated. But if he does have surgery, he is liable to have post-operative pain, and it might even be long-term. A 2017 paper by Hedberg et al., link in the description, illustrates how this consideration is not addressed. This research looked at quality of life in several hundred patients who had had laparoscopic repair of an asymptomatic inguinal hernia. The authors reported the following conclusion. Asymptomatic individuals undergoing totally extraperitoneal laparoscopic inguinal hernia repair reported less post-operative pain, returned to baseline activities, and discontinued pain medications sooner than symptomatic patients. But if asymptomatic patients, who by definition had absolutely no pain in the first place, and who perhaps didn't need the operation, are put into pain, are we certain they are better off? And indeed, is it right that certain medical centers are now offering free screenings so that people can find hernias they did not even know they had? Link below. Meanwhile, when mesh is inserted, as it so usually is, it is intended to be in the body forever, where it seems it may, over time, shrink, harden, and if the person is unlucky, cause interminable pain. Mesh manufacturers deny that the mesh used in inguinal hernia repair causes problems, and will soon be able to explain this, as thousands of hernia mesh lawsuits are pending at the time of uploading this video. Nevertheless, one complication, the risk of mesh migration, is medically well recognized. It has been described by surgeons as a probably underestimated emerging complication. And it is hardly a negligible one, given that certain surgeons feel its risk is so serious that it ought to be discussed as part of the patient consent process. However, even with a non-mesh technique, still the abdomen must be opened, the musculature cut, and there is the risk of a hospital-acquired infection, whether from the hospital stay, think MRSA, or from the actual surgery. The Global Alliance for Infections in Surgery cites the reported incidence of mesh infection following hernia repair as ranging from 1 to 8%. link in the description below. And surgical site infections in general are a particular risk of abdominal surgery. As Tubra et al. In 2018 concluded, link below, surgical site infections lead to significant morbidity and mortality, hernia recurrences, prolonged hospital stay, and increased hospital costs. This makes surgical site infections the Achilles heel of abdominal wall reconstruction. Is surgery ultimately always inevitable for inguinal hernia? How did people cope at a time when mesh did not exist? Was it possible for certain people that surgery might never be necessary? As previously remarked, Sir Astley Cooper was one of the foremost surgeons of his time. A plaque outside his boyhood home in the village of Great Yarmouth, in the county of Norfolk, England, describes him as follows. Sir Astley Cooper, 1768 to 1841. Surgeon to Guy's Hospital, London. Surgeon to King William IV and Queen Victoria. Anatomist. Surgical pioneer. The following reading provides 4 of the 35 chapters of the 1844 second edition of his book on hernia. And the book is of interest because it does report cases of hernias being cured without surgery. The reading comprises Chapter 1, General Description of Hernia. Chapter 3, The Oblique or Common Inguinal Hernia. Chapter 4, Of the Causes of Hernia. And Chapter 5, Of the Reducible Inguinal Hernia and Use of Trusses. The author's reports may be unreliable, but they cannot be wholly dismissed. When a surgeon of his esteem writes in the preface, I have therefore related no case and given no remark to the truth of which I cannot vouch. Indeed, in the 1820s, Sir Astley himself described to his students about his own successful use of a truss as a medical student, self-diagnosed after a lecture. He wore it for 3 years, after which he had not the slightest appearance of the complaint, but continued for 2 more years just to be sure. Link below. And at a time when mesh surgery can leave people contemplating suicide, links below. This makes interesting reading. Reading.
Anatomy and surgical treatment of hernia. The anatomy and surgical treatment of abdominal hernia with numerous plates. By Sir Astley Cooper, Bart, FRS, Surgeon to the King and Consulting Surgeon to Guy's Hospital. From the Second London edition, by C. Aston Key, Senior Surgeon of Guy's Hospital and Lecturer on Surgery. To Henry Klein, Esquire, Lecturer on Anatomy and Surgery and Surgeon to St. Thomas's Hospital. My dear Sir, 2 reasons strongly impel me to dedicate the following work to you. The one is that many of the ideas which it contains have been derived from your public and private instructions. The other, that it gives me an opportunity of acknowledging, with gratitude, the kind attention which I invariably experienced from you whilst an inmate of your family. That you may long continue to enjoy an exalted professional reputation, acquired solely by merit and unsullied by a single unworthy act, is the ardent wish of your sincere friend and colleague, Astley Cooper.